Hello, my name is Janet Acevedo, and today I will be presenting the QI project, Improving Pain Reassessment Documentation to Enhance Patient Safety. Let's take a moment to speak about pain reassessment. In our facility, pain reassessments are required 30 to 60 minutes after pain medication administration. And we have noticed an inconsistency and documentation of pain reassessments after interventions. Timely reassessments make sure that patients are comfortable. It helps us see any early signs of medication reactions or opioid induced respiratory depression. This is very important, especially on the oncology unit, because patients are often admitted for intractable pain. And this project also aims to align documentation with the Joint Commission's pain management standards to improve compliance and safety. Problem identification. The problem we identified is that the average compliance for pain reassessment documentation is 60% on the oncology med-surg unit. The staff cited that this is due to several workflow interruptions and the complexity of the EMR. There have recently been updates to the pain reassessment documentation in the EMR, and it includes several clicks and several pop ups to document a pain reassessment with hard stops. Nurses are stating it is extremely difficult to add this new complex EMR addition to their workflow. Missed reassessments lead to unmanaged pain, safety risks, and poor patient satisfaction. The issue directly links to the Joint Commission's National Patient Safety Goals and the CMS quality reporting indicators. So, as stated previously, the Joint Commission emphasizes reassessment of pain and monitoring for adverse effects after interventions, as well as the CDC. The American Society for Pain Management Nursing highlights the early identification of sedation and respiratory depression prevents serious harm. Aim and measures. Our aim is to increase compliance from 60% to 90% within a 6-month period. The process measure is the percentage of reassessments completed within 30 to 60 minutes after pain medication administration or pain interventions. The outcome measure will be the number of opioid related adverse events per month, which we would like to ideally be little to none. And the balancing measure will be the nursing time spent documenting pain reassessments per shift. This is a driver diagram that shows the aim, primary drivers, secondary drivers, and change ideas related to pain reassessment documentation. We would like to see pain assessment documentation on the oncology med surg unit to improve to 90%, which is within 6 months. The primary drivers are workflow and time constraints, staff education, and EMR usability. These secondary drivers are EMR reminders, simplified documentation steps, audit feedback, and staff accountability. And the goal is to standardize and sustain pain reassessment documentation above 90%. This is a flow chart that represents the steps for pain reassessment documentation and pain assessment. So we're going to start with the nurse assessing the patient's pain. Once the nurse assesses the patient's pain, They document the initial pain scale, their respirations, and they use the Pacero scale to determine the patient sedation. The next step is medication is the medication warranted? If not, then continue to monitor the patient's pain per protocol, which is every 4 hours, or if the patient calls or you notice a patient grimacing or they're saying, "Hey, I'm hurting." If pain medication is warranted, the nurse then will provide medication, document the medication, respirations, Pacero, and the pain scale. After that, the nurse will wait 30 minutes, reassess the patient, document reassessment, pain score, respirations, Pacero, and pain scale. Is the pain controlled? If not, you will contact the provider for further orders to administer the next level of ordered pain medications. You will contact the provider for further orders or administer the next level of ordered pain medications per your mark. And then go back to document your reassessment within 30 minutes. If the pain is controlled, you will continue to monitor the patient per protocol every 4 hours, or if the patient states, "Hey, I'm hurting." Um, the bottlenecks identified from this flow sheet or flow chart are the EMR delays, unclear reassessment timing, and communication. There are 15 clicks from the time you start a pain assessment to the time you finish. There are 15 clicks in the EMR. Interventions and plans for change. We would like to add EMR reminders. So we still want those hard stops that cannot be bypassed, but we want to reduce the documentation steps. Instead of 15 clicks and another page and another pop-up, we would like to be able to streamline this to make it easier for nurses to chart instead of making it harder. HealthStream online education will be mandated when this is rolled out. We will also receive input from nurses before rolling out anything. We will have beta testing by nurses. This is going to be heavily nurse driven because they are the ones who are experiencing the charting every day. Educators will be rounding for 2 weeks after initiation of this new policy and the new AMR rollout to reinforce expectations and to answer questions. Eventually, we will do monthly audit feedback to share compliance rates with staff. However, we are going to start weekly feedback to ensure everyone is on the same page and everyone is compliant. We will introduce paper reassessment sheets for backcharting when EMR access is delayed. These will be located at the nursing stations or on the web. This is a run chart which ideally shows a gradual increase in the percentage of pain reassessment documentation within a 6 months period, leading to a 90% compliance. Our evaluation plan is to collect data via the EMR audit reports and paper logs showing us how many pain reassessments are being done in a timely manner. We will monitor, we will be monitoring through educators and QI nurses for 6 months. The data will consistently be compared to the 60% baseline and remain at a target of 90% or higher. And the results will be documented in monthly reports and shared with leadership and staff. We do encourage incentives for staff members who reach over 90% compliance, such as meal tickets. Sustainability plan. Once 90% is reached, 90% compliance, we will integrate pain reassessment training in new nurse orientation. So we will continue to teach appropriate pain reassessment measures. We will also integrate this into the nurse residency program. We will continue monthly audit feedback cycles. We will recognize high performing staff to maintain engagement. Like as stated before, things like meal tickets, uh, verbal recognition in front of staff that really encourages team members to perform high. And we encourage ongoing EMR system feedback for future updates. In conclusion, improved reassessment documentation does promote patient safety and compliance with national standards. We would like to streamline the workflow and obtain real-time feedback to improve staff accountability. This project demonstrates that small system changes can produce measurable and sustainable improvements in nursing quality. I would like to thank Jennifer Ashley, my mentor and the unit manager, and also Brittany Heights, the project coordinator, who has also been like a mentor to me and has helped me to really organize my thoughts and organize this project. And I would like to thank the oncology nursing staff because without their input, we would not be able to get to the root of the problem. I thank you guys so much for having an open mind and believing that we can really make a change for the positive. Thank you for listening. Have a great day.